From the JAMA Network, this is JAMA Internal Medicine Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Internal Medicine.
Hello and welcome to our listeners around the world. This is Dr. Eve Rittenberg, and you're listening to JAMA Internal Medicine Author Interviews. Thanks for joining us. Today we'll get a quick glimpse into an important issue, which is how often older adults are stuck for prolonged amounts of time boarding in emergency departments. And we know that for older adults, the obvious harms of prolonged boarding while they wait for an inpatient bed, like the inconvenience, the discomfort, the uncertainty, are magnified, and that these long stays are linked with a lot of bad consequences, including an increased risk of delirium and mortality. Today's study provides estimates of what is happening with emergency department boarding in the U.S., and I can't wait to talk to our guests. So rather than spoil the results of what they found, I will introduce them. Dr. Adrian Haimovich is an assistant professor of emergency medicine at Beth Israel Deaconess Medical Center, and he's the author of a research letter in this week's JAMA Internal Medicine on national trends in prolonged emergency department length of stay among older adults. So welcome, Dr. Haimovich.
Great to be here. Thanks for having me.
And Dr. Maura Kennedy is an associate professor of emergency medicine at Mass General Hospital. She authored a commentary that delves into the challenges and potential solutions to the emergency department boarding crisis. Welcome, Dr. Kennedy.
Thank you for having me.
So let's start with Dr. Haimovich. Adrian, what made you interested in figuring out trends in prolonged emergency department lengths of stay?
I think there are a couple pieces that came together all at the right time to ask this question. The first piece was the new age-friendly hospital measure, which was included in the CMS final rule last summer and comes into effect this year, so 2025. And this measure is a really interesting piece of policy that had some really amazing advocacy behind it and requires that health systems and hospitals attest to policies within 5 domains intended to improve the care of older adults. One of those domains is a frailty screening and intervention domain, which includes specific line items around policies and practices addressing older adults in the emergency departments, specifically how long they're in the emergency department from time of arrival to time to departure. And something that you already alluded to, a second point around boarding, which is the amount of time between when the decision is made to admit the patient and when they leave the emergency department to go to whatever their hospital bed will be. The development of this really interesting and important measure with the sort of availability of data to address this in the Epic Cosmos database. And on top of that, my own practice as an emergency physician who's interested in geriatric acute care just caught my eye, and I felt like this was a unique opportunity to address the question.
Was there something that you've seen in your work in emergency medicine that made you think this was important?
Only every day. I would say that the defining experience of being an emergency medicine physician in 2025 is the experience of boarding and hospital crowding and seeing suffering that our patients experience, especially those who are most vulnerable, which I think probably is arguably our older adults, especially those with cognitive impairment. And we see this every day in our emergency departments, and so shining light on it is a unique opportunity that couldn't pass up.
Tell me a little bit about what you did in your study and what your findings were.
Yeah, so we took a look at this interesting data resource called the Epic Cosmos database, and that's a de-identified voluntary contribution database that's managed by Epic, which is the largest electronic health record vendor in the United States. And within that, many institutions or many enterprises elect to share de-identified data back with Epic, which then is available for research and investigations. And so we use this database to look at trends in both of these measures, like how long older adults are in the emergency department, as well as how long it takes them to get their hospital bed after admission, that is to say the boarding measure, between 2017 and 2024. And our key finding is that in alignment with the clinical experience that all of us emergency medicine physicians have, that number is skyrocketing. And the percentage of older adults who have really long emergency department lengths of stay, so that's to say greater than 8 hours, has been climbing since 2017, peaking in the COVID years. And in parallel, our boarding rates, that's to say the percentage of patients who are taking a prolonged period to get their inpatient hospital bed once we've asked for it, is also skyrocketing. So It's nothing that surprises us as emergency physicians, but it does give the broader community the opportunity to think about it as well.
It's so distressing, the numbers that you found in terms of how much these rates have increased. People who are staying in the emergency department, not because of a medical reason, but because there's just no capacity for them. And so I'm going to turn to Dr. Kennedy. Maura, in your commentary, you shared some of the reasons that the boarding crisis is so commonplace and it's getting worse. I wonder if you could talk a little bit about that.
Absolutely. And it's a really complex issue, right? If this was a simple issue, we would have fixed it. And it's not a simple issue. There are many drivers that contribute to large numbers of patients boarding in our emergency departments. One is simply volume of ED visits. And we've definitely seen over the same period of time increasing numbers of ED visits and ED visits resulting in hospitalizations, especially of older adults. And so if we're seeing 11 million more ED visits by older adults, and about half of those are resulting in admission, that's just increasing the number of bed days that we need to take care of the older adults presenting to our emergency departments. Simultaneously, in a separate article that's published by JAMA Network Open, we know that over a similar time period, pre-COVID and post-COVID, the number of staffed hospital beds has actually decreased. So rising number of ED visits, rising numbers of hospitalizations, and decreasing number of staffed hospital beds means more patients who are boarding in the ED. Our patients are often sicker nowadays due to multi-morbidity, multi-complexity, and so that drives longer hospital lengths of stay. That contributes to the capacity challenges. And there are a lot of other drivers outside of the hospital as well. Many of our patients have to go to post-acute care, for instance, and staffing challenges in post-acute care and bed availability there are challenges as well. Outpatient capacity is an issue, so sometimes patients just can't get the care they need in the outpatient setting, and that results in patients presenting to the ED or coming to the ED very sick. And so those are just a number of the many components. I do personally think there's another element that is difficult to demonstrate, but I think boarding itself is actually contributing to boarding. Boarding begets boarding. And I think of this mainly in terms of our older adults who have issues with cognitive or functional decline. If you're an older adult and you're in my emergency department for 8 or 9 hours, the likelihood that we have ambulated you around the emergency department is very low. The likelihood that we have brought you a meal is better, but still very probable that you may have a missed meal, less hydration, and that results in functional decline. We know from lots of literature that longer ED lengths of stay, as you noted, is associated with delirium, including a study that I co-authored. Delirium itself is associated with longer lengths of stay and functional decline, and you add those together, that's contributing to longer hospital lengths of stay, so that patient needs a bed for longer, which in turn means a bed that's not available for another patient. The circle where boarding a frail person in the emergency department may just drive longer hospital lengths of stay for them, need for post-acute care, and then take away bed availability for other patients that are coming in.
So given all of these dynamics, what are your thoughts about potential ways forward or potential solutions to these prolonged stays?
Yeah, so yes, it sounds bleak from what both Adrian and I have said, and I apologize. I do think there's reasons to be hopeful. So the AHRQ last year had this enormous summit that brought many people from across the healthcare arena together to talk about boarding, and they recently, in January of 2025, released a report about that. So I do think there's a lot more attention on a policy level. I think the CMS measure itself is an important contribution because it brings national attention to the boarding issues, and hopefully from there we'll bring more people together to try and address it. I think there's some levers in hospitals that we can do. They won't address the capacity issues, but maybe address the quality of care while someone is boarding in the emergency department. For instance, in our hospital, we have a hospital boarder program, and we have some boarder nurses who assume care of some of the patients who are boarding and try to both progress their care and provide the sort of nursing care you might have up on an inpatient floor. So those are some things we can do individually. But on the larger picture, I honestly think we need to build capacity outside of the emergency department and outside of the brick and mortar hospital. I really think that we need to focus on what are those other opportunities for this population to provide care in the home, in the long-term care facility, where we can hopefully keep them out of the emergency department or keep them out of the inpatient setting, still deliver high-quality care, but just in a different setting.
you touched on some of this, but I'm wondering for both of you, if you have suggestions. I'd like to include a little bit of a clinical pearl from this. So amidst all of these stresses in the emergency department, and as you said, particularly challenging for older adults and for the folks who are kept in the emergency department for long periods of time, do you have suggestions that clinicians might be able to offer to older adults who land in the emergency department to either lower that risk or mitigate the harms from prolonged boarding?
I can take a swing at that. I think that there's an opportunity to empower our older adults in several key ways. One is supportive family members, supportive caregivers are a really potent tool to helping keep our older adults safe in the emergency department setting, given all these risks that surround them. And then the second thing that I think about often is what a critical part of shared decision making, boarding and crowding and prolonged hospitalizations should be. And what I mean by that is that when physicians like myself and Maura talk to our older adults who don't necessarily have a clear indication for admission and maybe are on the fence about the necessity of admission, thinking about the exposure of boarding and crowding as part of the risk profile of what they will experience if they're stuck in the emergency department and stuck in the hospital for a long time is really important. We should be empowering similarly our older adults to think about the hospitalization experience as part of their shared decision-making process for what they think that they need to be successful in terms of achieving their health outcome goals.
And I think about this a lot through the Geriatric Emergency Department Accreditation Program. So I serve on the board of governors for this program that accredits emergency departments as geriatric EDs. And we released these 2 new care processes related to boarding and provide some framework or guidance for that. One of them is to identify those patients who may be most harmed from boarding in the emergency department and trying to accelerate their admission. So when I think about that, I think about persons with dementia who are most at risk for delirium. I think about people with physical disabilities who might get pressure sores from being in a stretcher for a prolonged period of time, or who are most at risk for functional decline from being immobile. Those are some of the things that I think about. And there was an article by Roussel in JAMA a little while back that looked at mortality associated with boarding, which you alluded to earlier. And it was individuals who needed help with their activities of daily living who were at the highest risk of mortality from prolonged ED boarding. So I think that's one piece. Who is most at risk from harm from being in our environment and accelerating their admission? The other piece is just trying to address the care in the emergency department. So I mentioned earlier the hospitalist program that we have. So patients are seen by a hospitalist and medications are ordered that they need for their care, and try and progress their care by ordering necessary tests that you would normally do in the inpatient setting. In addition to that, thinking about the environment. So are there ways we can mitigate the harm of our environment? So putting patients in a more quiet area where the lights can be turned down, where they can get sleep at nighttime, or providing things such as headphones and masks so that at nighttime maybe they can fall asleep. And then the other piece is just trying to normalize function, which again we talked a little bit about, but making sure patients are getting food, are hydrating, are mobilizing regularly, are getting walk to the toilet as a simple way to get 2 in 1. But I think there's some things that we can address from a physician and nurse level to improve sort of their care while they're boarding in the emergency department, and then trying as best we can to address some of the challenges related to the environment of the emergency department.
I've learned so much in this short conversation. Really appreciate you both being here. I'm Dr. Eve Rittenberg, and I've been speaking with Dr. Adrian Haimovich and Dr. Maura Kennedy about trends and the importance of prolonged stays in the emergency department. You can find a link to the articles that we discussed in this episode's description. This episode was produced by Shelley Steffens at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. Thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.